Yeah. Next we have Dr. Henna Aboobaker, who will be talking on SSOCT evaluation of anterior segment in occludable angles, topical pilocarpine versus laser iridotomy.
Good afternoon. My study is on SSOCT evaluation of the anterior segment in occludable angles, topical pilocarpine versus laser iridotomy. There is a huge burden of primary angle closure glaucoma in Asia. So there is a need to detect this disease spectrum at the stage of primary angle closure suspects. It's known that gonioscopy is the gold standard for detection of narrow angles, but it is subjective and needs more expertise. Imaging modalities with the advent of newer web source ASOCTs acquire high resolution images of the angles with a relatively shorter acquisition time, and it's more objective. Previously, pilocarpine has been used for narrow angles, for treatment of narrow angles, but nowadays laser iridotomy is the standard of care. So the aim of our study is to assess and compare changes in the iridocorneal angles after pilocarpine instillation and laser iridotomy in primary angle closure suspects using SSOCT anterior. Ours is a prospective observational study conducted in 50 occludable angle patients conducted over a period of 1.5 years. Subjects more than 40 years were included in our study, and those with secondary angle closure and corneal pathologies were excluded. So, PAC is recruited after 4-mirror gonioscopy by a single examiner, and 3 anterior segment OCTs were taken. Firstly, at baseline when the patient comes for laser PI, second after 30 minutes of pilocarpine administration, and the third after 1 week of laser iridotomy when the patient comes for review, and these 3 measurements were compared. This is the anterior cross-sectional image of the angle. All the angle measurements were dependent on the accurate manual positioning of 2 parameters, 2 points, the angle recess point, which is shown in red, and the scleral spur shown in yellow. And the measurements were taken at 500 and 750 microns from the scleral spur as shown in the right side. The angle parameters taken were anterior chamber angle or ACA, trabecular iris space area or TISA, angle opening distance or AOD, and scleral spur angle SSA. These were measured at 500 and 750 microns from the scleral spur in both the nasal and temporal quadrant, hence a total of 16 angle parameters. Besides this, anterior chamber and lens parameters were anterior chamber depth, volume, lens wall, and lens thickness. Coming to the results, in our study majority were females, and this table shows all the 16 angle parameters on the left hand side, and P1 showing the significance of the angle with improvement baseline versus post pilocarpine, and P2 the significance of improvement post laser PI, and it is seen that a widening of all the angle parameters post laser was seen as seen in the right hand side, and significant widening of most of the parameters except 3 parameters for after pilocarpine instillation. So it's seen that laser iridotomy widens the angles better than pilocarpine. The most significant angle improvement was seen with anterior chamber angle in the nasal and temporal quadrants, which was followed by angle opening distance. The same is shown in this box and whisker plot of anterior chamber angle widening. There was progressive widening post pilocarpine and post laser. And this slide shows pilocarpine, that pilocarpine reduced the mean AC depth and volume, while laser increased the anterior chamber depth and volume. And lens wall significantly increased post pilocarpine and decreased post LPI. Coming to discussion, post-pilocarpine AC depth decreased in our study and lens fault increased, which was supported by Rachel et al. And post-laser AC depth and volume changes were supported by Zebardast et al. Meduri et al. Was the only study seen done in occludable angles using anterior as done in our study, but our study had more sample size, and in both the studies in the temporal quadrant there was statistically significant widening of the angle measurements post laser, and but in the temporal quadrant maximum improvement was seen with AC anterior chamber angle in our study, and whereas with trabecular iris space area in their study. And this is showing other similar studies using different ASOCT machines and showing the angle width improvement. And Rachel et al. Showed the effects post pilocarpine and laser PI in narrow angles and showed greater widening post laser than post pilocarpine. Coming to conclusion, laser PI is very effective in widening the iridocorneal angles in primary ankylosing suspects as assessed with anterior, and the greatest widening was noted with anterior chamber angle and angle opening distance. Pilocarpine also significantly improves the angle width, but to a lesser extent than laser iridotomy. My references. Thank you.
What is the mechanism of action of pilocarpine?
Pilocarpine stretches the root of the iris so that it opens the angle and helps in drainage of the aqueous.